The real reason your joint degeneration patients keep relapsing. You're just treating the joint, and that's why the problem keeps coming back. A patient's knee feels great when they leave your office. Then, a week later, they're back. Same pain, same spot. And it makes you wonder, did you miss something? Listen, you didn't miss a technique. You treated the joint. But the joint was never the problem in isolation. Here's what I've learned after helping hundreds of patients cancel planned joint replacements. The rehab that fails long-term almost always treats the structure in isolation and ignores the system that's loading it. Treat the symptom and the system recreates it. I run Grip Approach, and we get brought in on cases where everything else has failed and still get 90% successful outcomes. So don't click away. I'm going to show you where most rehab plans fail and exactly how to implement rehab in the right order to get results that stick. Pain shows up at the joint, so that's where the treatment goes. But the joint is the site, not the source. The first failure point is treating the site of pain, not the source. When we look at a knee that gets painful, it might be due to underloading or overloading or some type of misuse that leads to inflammation within that joint, activates the pain-sensitive nerve fibers, that shoots up the spinal cord of the brain, and your brain makes a decision that this is uncomfortable, this is painful, and it's asking you to make a change. And fortunately, there's a lot of non-surgical things that can be done to change the pain response in the joint. And there's many rehab systems that can do this. We can exercise a joint, we can load a joint in a specific range of motion, we can rub the tissues around the joint and get a positive change in the experience of pain. But we have to keep in mind what we're doing with that is we're sending a different signal up the spinal cord to the brain, and we're trying to change the way the brain interprets symptoms in that joint and make a friendlier interpretation, a less painful interpretation. And this is why a lot of rehab techniques can actually get very positive short-term outcomes, very positive reduction in pain, potentially even a reduction in pain that then gets the patient moving, and that's excellent. But the trap in that is that if we treat things with the goal of immediate short-term improvement, we don't necessarily get to the system that created that painful trigger. We're turning the alarm off, but we're not doing the right things, or we're not doing the right things at the right dose to get a long-term change to prevent the system from breaking down that joint. And then we end up getting a recycling of the pain, and the patient thinks, I tried rehab, it felt a little bit better, but here I am 6 months later and my knee is bad again. Maybe it's worse than it was before. And so that's a trap. That short-term outcome, we can all achieve it for the most part, but we haven't done things to address the system long enough or at the right dose to actually drive the long-term results that we need to stick. So why does this happen? Why do we address the tissues short-term but not the system? I think many of us struggle to identify exactly why the system was leading to this breakdown. For one patient, it might be that they did too much all of a sudden and we get an overuse type of inflammation and breakdown. For some patients, they do far too little. They don't prepare their cartilage and their bone to be strong. They don't send that signal to the body that we need repair, we need strengthening, we need good cartilage, and so the body's efficient, it starts to break down. For some patients, there's an issue in the foot that's changed the mechanics in the knee, and rather than that knee holding kind of neutral load, we've tipped, and now we're getting excessive load on one portion of the knee and not much load on the other, and that creates an isolated overuse. These are many different ways why a knee tissue might break down and cause pain, but unless you look kind of globally and understand what's unique about that person, then all of your efforts are going to be on the short-term results within the knee and not necessarily the system that creates it. Now, you're really good at what you do, so you can turn that alarm off, but this is part of the failure within the rehab model is you're turning that alarm off, but you're not changing the trigger for the alarm. So this is why that joint keeps flaring. you're very good at what you do. You're very good at resetting that alarm and turning the alarm off, but you haven't necessarily fixed what's triggering the alarm. The second failure point is not having a system that ties all of your findings together. This often leads to a scattershot approach where you do trial and error. We often think of this as like throwing darts at the wall and hoping one of those darts sticks. And that trial and error is inherent to healthcare. It's how everything evolves. We try something, we observe the results, and we see if it works. Every system evolves that way, including our own. But if you never tie that into a system, then it's always a case-by-case trial and error, and it's hard to build that up, get consistent results, and scale. So in what I teach, we're going to have a system where you start to evaluate every case the same way. So you can compare case to case. It makes it easier to identify an abnormal result that you need to focus treatment on versus a normal variance versus a healthy result that you can avoid. And in this way, you're tailoring your treatment specifically to that individual, but you're doing it in a systematic way that doesn't have you wasting time with trial and error on things that are going to be ineffective for that patient. Here's an example. One patient that comes in might need to restore terminal knee extension, and you load and load and load that terminal knee extension. Their gait improves, their comfort improves, and that was very successful for them. Your next 5 patients come in, and that's not their issue. But because you had that result previously, you do the same exact treatment and you don't get the same result. So you move to the next treatment, and maybe that next patient needs BFR strengthening through the knee, and you finally find that that works. And so you start applying that to the next case that might not need that. That trial and error can still be effective, but it's a slow and sloppy way to approach this. And when a patient says, "You are my last hope, I've tried everything, it's failed, I don't want to get the surgery, fix me," I would rather you have a system that tells you exactly how to operate versus doing trial and error. And I think for me, the only thing worse than doing something wrong in treatment is doing it time and time and time again. And because the language of how we work with cells is load and repetition, really the only thing we can do is repeat and repeat and repeat. And I'd rather you get the right system of evaluation, the right system of rehab in, so that you're repeating load in the right target to get the results that your patients are looking for. The third failure point is that the assessment and the treatment is not linked. This is why a lot of students in healthcare learn their orthopedic tests, but never view them as something that can inspire a precise type of treatment. And so it's necessary to have an assessment that is actionable. We want you to be able to test the knee so you can objective findings and know exactly what's going on, but we don't want it to stop there. We want that assessment to tell you exactly which tissues you need to treat and which rehab you need to implement and how you need to dose it. And that's how we build GRIP, is that there are tests for everything. You'll be able to see any joint, any presentation, and have a test for it. And then every test is meaningful. I won't show you a test without showing you the treatment that is applied to that test to get good results. So here's an example of this. A patient walks in, they've got frozen shoulder, and you run some movement tests, some rotator cuff tests, and you find, okay, they've got weak supraspinatus, they've got weak infraspinatus. All of these rotator cuff muscles are testing weak with manual muscle testing. And the old school training might tell you, hey, they might have a rupture in all of these tendons. But if we tie this together with what we know about the capsule and maybe controlled range of motion, these might be artifact findings. They might not be something that we need to treat like a ruptured rotator cuff tendon or a partial tear in a rotator cuff, because the overarching presentation is frozen shoulder. Now, if we approach that case in a different way and we say, okay, show me your controlled range of motion, and we take the glenohumeral joint through specific ranges of motion, we now have hard data. Let's say they can only bring that shoulder up on their own to 70 degrees out from the side. And then you can apply a rehab technique specifically for that shoulder abduction, lateral humerus. And if you see a 5 or 10% improvement, they go from 70 to 78% in a few minutes, at that point we know that this likely is not a tear or a rupture. It's more likely to be a motor control deficit, and we have built into that a rehab technique that they can start to recycle and load at home. And if it's ineffective, we know exactly which tissue we want to treat to inspire that, and we can test it again afterwards. So a good assessment should give you clean, measurable data about the body and the body region that you're testing, but it should also be actionable. It should show you which treatments to tie into that so you can get more effective results and do it pretty efficiently with your team. Quick note before we move on, and don't click away. The next 2 points are what's costing you the most, so finish this out. If you want a systemized version of everything I'm walking through, I've got a breakdown of the non-surgical joint replacement available for download. The link's in the description, so just finish the video and then follow up with that link. The fourth failure point is ignoring load capacity, or the joint's ability to adapt. Long-term success always involves restoring the joint's ability to tolerate and adapt to load, not just calming the joint down. This is why the non-surgical joint replacement approach focuses on tissue repair and tissue cell replacement. It's an adaptive, regenerative, anabolic process. Our body goes through these processes naturally, but as we go through the process of repair and replacement of cells, we're also going through the process of cell breakdown and degeneration, which is catabolic. And those two systems, they're both necessary, but when they get out of balance and our tissues break down and degenerate faster than we can repair and replace, this is when we get joint degeneration, joint arthritis, and we start this cycle that's both structural and hormonal in the way a joint breaks down, and we've got to shift that balance. The only way to really shift that balance effectively is to improve the loading mechanics of the joint, the load progressions of the joint, and the biochemicals that we wash those joint cells in. So those three pieces, let's break those down. If the joint mechanics are off, let's say there is stiffness in a joint that's forcing increased load in one specific element of the joint and decreased load in another, two adverse things happen within that joint. The area that's not getting effective load becomes softened. It doesn't have as much stimulus to repair and replace. It's underloaded. And the portion of the joint that's getting increased pressure might be getting that increased pressure at such a rate that it can't adapt to it, and we get overuse on the cartilage in that particular portion of the joint, and that's going to lead to adaptation of the joint. We might get some cartilage fissures, we might get some increased bone in that area to try to stiffen up the area. So it's two different patterns of breakdown based on how that joint is loaded, and if we shift the mechanics slightly more towards neutral, a 5 or 10% change, then we can shift what's happening both at the underloaded and the overloaded portion of the joint. This is why the mechanics of the joint do play a role in both underuse and overuse trauma. Typically, when a patient goes to their primary care doctor with acute joint pain, there's going to be 2 or 3 things that happen. First, if it's really severe, they might get a Toradol shot to impact pain that day. Then they're likely going to be told to take ibuprofen and to rest the joint for 7 to 10 days and see if that impacts the pain. And while they are resting, they're not giving the joint and the cartilage enough stimulus to repair. We need exercise. We need exercise to be chondroprotective for the joint. And if we couple that with oral anti-inflammatories like ibuprofen, well, ibuprofen is chondrotoxic. It's unhealthy for your cartilage to be exposed to ibuprofen. Whether it's systemic or injected, it's going to weaken the connective tissue and the cartilage. So we're doing 2 things that are chondrotoxic: sedentary rest and ibuprofen. And we're not doing one thing that's known to be both anti-inflammatory and chondroprotective, which is exercise. But this still might work in the short term. This might take the alarm down and the patient might feel more comfortable. They might feel like they're on the right track, but that's purely a calm stuff down approach. And they might think that my success in calming this down is tied to rest and ibuprofen. And every time they have that symptom occur, they might then treat it with rest and ibuprofen. And while they're calming down their brain's response to this inflammatory presentation, they're also preventing the body's natural process of repair and replacement of those cells. And the only way to break that cycle is to get them off of ibuprofen and get them exercising. And we need to do that by finding the right load tolerance and then progressing it from week to week. So what does that look like? Initially, for your patient, it might be extremely simple. If I can't get a patient to move at all, I might do something light, like blood flow restriction training passively, just occluding some of the arterial flow into the limb, as well as the venous return. And by doing that, we create this hypoxic environment in the muscles and tendons in the knee, and we trigger hormone response that's similar to exercise. And once they can tolerate that, we're gonna get them moving, whether it's open chain or closed chain, and we're gonna progress them up the cycle from doing these open chain exercises to actually planting the foot, planting the knee, planting the hip, and moving the body over those limbs on ground-based exercises. When they can tolerate that well and they're loading that at home, we're gonna add some big compound movements. We might be doing hip hinges or lunges, or if it's the shoulder, we might need to get them to do a row or an overhead press, these gradual progressions of load. And finally, we're gonna add resistance. We're gonna add free weights or resistance bands, or we're gonna have them push against us while we push back against them, or progress into ballistic movements where we move that tissue quick. And this whole thing's a scale. And when you see your patient, we've gotta see where on that scale is their starting point. And if their starting point is here, I can't exercise them all the way over here. Otherwise, they're gonna flare up and they're gonna treat that with rest and ibuprofen. But if their starting point is here, I also can't keep them way down here in extremely low load and minimal movement. If I keep them here, they'll never progress. I've got to meet them where they're at, and as soon as they can do activities in this range and recover by the next day, I've got to move that range a little bit. I've got to start exercising just above where their capacity is. And once they can do that and recover the next day, we take another step. And we got to move along this scale. So that progressive exercise is vital to getting restoration of a degenerative joint. Failure point 5 is no system to scale and reproduce your results. Even exceptional outcomes are gonna fail at the practice level if everything falls on one provider's head. If you don't have a system to cleanly reproduce what you do, reproduce the outcomes that you can create, but scale that into other providers at your level, assistants that work with you, and the team around you, then this can become very overwhelming for you as a provider. We don't want you to be the only hero in the practice. We don't want the patients to only offer to work with you. You need to build a team around this. And in my office, the ideal here is that the main assessor is a specialist in assessing a case, writing a case, and understanding where they need to go. But then we work with a whole team to deliver the treatments. Multiple different people can mobilize the joint the way we need to mobilize it. Multiple different people can apply things like shockwave therapy or dry needling, BFR, rehab, exercise progressions. They can all fill in and help only because we have this as a clean system. So the goal here, you might be a hero to your patients, but the goal is that you are not the only hero to your patients, and that this is a team approach. And it's built as a team approach on a logical system. So we're gonna systemize the way we teach you in a way that you can hand this off to other providers in your practice, to assistants and extenders that help to deliver your care, and as a whole, you're going to be changing outcomes and improving outcomes together. And in that way, you can scale this within your practice And you can also scale it to additional practices or additional locations. So this is plug and play. You should be able to do, if you follow along, you should be able to do this yourself, but you should also be able to bring your team on board so that everybody in your practice can deliver this method. And if you'd like to, scale it to multiple locations. So I'd like to share with you a sample case that's been very inspiring to me and why I teach the non-surgical joint replacement. I'd like you to think about my patient, Sarah. Sarah came to me after trying everything for her knee. She was relatively thin, in her 50s, an avid tennis player, and she played tennis until her knee said no. And after her knee said no long enough, she picked up pickleball and she tried playing pickleball, and that went okay for a while until her knee said no. And then she shifted to jogging and then to walking. And then she realized that all of these activities that she loved, the community around them that she loved that made her who she was, were all things that she could no longer do before because of her knee. She tried rest, she tried activity modification, she tried oral anti-inflammatory, she had corticosteroid injections in her knee, and still her knee was stopping her from doing the things that she loved, the things that made her who she was. And so she asked her provider, what's next? What can I do? And of course, the first recommendation for Sarah was a knee replacement. And I think that that's sad, honestly, that the only option at that point was to cut the knee out of her body, discard it, and put in a new one with no expectation of how long a rehab process might take pre and post surgery, whether or not she was going to lay down a lot of scar tissue, whether or not she had autoimmunity that would complicate surgery. It was the only option that was given to her, and she was seriously considering it. And she checked into my office and she said something very simple to me. She asked me, will you try anything that you can do to make it so that I don't have to get knee surgery? And I wasn't really sure what I could do for her. I did my assessment. I looked at the imaging, I saw the cartilage defect, I saw the stiffness in the knee. We looked at the mechanics around the core, the hip, the foot. We looked at the sports that she loved to play, the rotation and the side bending that the knee had to tolerate in addition to bending and flexing. And when I looked at everything, this was a grade 3 to 4 knee degeneration, which had rapidly escalated over a 2 to 3 year period of time. And in those cases, my initial training as a chiropractor may have been refer this to the orthopedic surgeon. This is a stiff degenerative knee. But she asked me to try. So I dug into the research. I looked at all of the different ways that we could inspire tissue repair and replacement within the joint, and we put together a plan. And I told her really simply, surgery might be an option for you. Here are the things you tried that weren't effective. Here are the things that you only lightly tried, and here are the things you didn't try. And let's build together something consistent for 6 to 8 weeks, and let's do everything right for those few months and see where you're at the end of it. So in her assessment, we identified the movements that she needed to regain control of. We looked at the muscles that she needed more strength to. We modified the diet. We added in some shockwave therapy to the subchondral bone to try to get some better blood supply and stem cell activity around that subchondral tissue and inspire cartilage regeneration. We used BFR training around the upper thigh so that she got a bigger growth hormone impact for even light load exercise. And it was pretty amazing. The first 2 or 3 weeks, pain reduced and range of motion improved. That continued throughout the 2 months. As we got into week 3 and 4, we started to notice strength gains. She was able to tolerate more activity with less pain afterwards. Her walking gait began to normalize, and at the end of the 2 months of care, we had Sarah with a knee that was strong. It was resilient against bending, flexing, side motion, and rotation. She was doing some single leg hop downs off of a block to help control rotation and prepare her for tennis. And we'd started to get back to pickleball, which was a good step in the direction. And that took 2 months of doing everything right. And I really think that if she didn't follow my advice on the diet, we wouldn't have had those results. And if she wasn't willing to do the low-level rehab at the beginning, we never would have been able to progress to the higher levels of load. And if she didn't really commit to doing those higher levels of rehab, we might still be stuck in the same degenerative knee that needed surgery to get her life back on track. But she did fully commit. We had a full system in place. And through those 2 months, I only provided 10% of her care. Our team provided the majority of it. And now Sarah's back to pickleball. She's back to tennis. Is her knee pristine? No. If we look at an x-ray, there are still degenerative findings on the x-ray. Is her range of motion improved? Yes. Is the cartilage improved? Yes. Is the strength improved? Yes. All of the things that are necessary for repair, replacement, and getting better each year, they're all in play right now. She's getting better every year versus getting worse. And that only happens with the right system in place and a patient that's committed to doing the right things. So I think it's a wonderful story. It's a great case example of how you can really turn around a case, but also prevent somebody from getting a surgery that might actually be more of a setback for them than a step forward. Rehab doesn't fail because you're not skilled. Rehab fails because the system around the joint was never addressed. No one taught you how to treat the system. So that's why most joint rehab fails long term. It treats the symptom, not the system, and that's why the results never stick. If you want to learn the system of assessing degenerative joints, triggering non-surgical repair, and tying it all together into a repeatable approach for your team, that's exactly what we teach in the non-surgical joint replacement series. If you'd like quick, immediate access, the first link in the show notes, the description, is a link to the non-surgical joint replacement summit. That's 3 days of content, one for the hip, the knee, and the shoulder. If you prefer learning in person, the second link goes to our live courses that are upcoming, where you can join me and get hands-on mentoring in person. If you're a chiropractor, physical therapist, athletic trainer, medical doctor, DO, and you're sick and tired of getting poor rehabilitation results or only being able to send those degenerative joints out for surgery, then this course is for you. My mentorship is for you, and I'd love for you to become part of the change we're creating with the non-surgical joint replacement. So click the links, sign up, and I'll see you on the inside.